So, the first thing we need to look at is the child's overall medical history, especially when it comes to chromosomal abnormalities or the surgeries that a child would have. As we know from our work with children, many of them who have genetic syndromes may have a hyperresponsive gag reflex. Many of these children also have neurological diagnoses that can exhibit a symptom of having a hyperresponsive gag reflex. And if a child has had a lot of surgeries, he may have difficulty with controlling how responsive that gag reflex is well. We also want to be aware more specifically within the child's medical history of any invasive procedures, especially like feeding tubes, and I'm talking more like orogastric or nasogastric feeding tubes, and then any instances where intubation had to be completed. So because these situations are very forced upon a child, feeding tube or a breathing tube is forced within the oral cavity or down in the pharynx. It's very intrusive to the child, and that alone can cause quite a bit of oral aversion and a very responsive gag reflex. And then lastly, we also need to think about those children who have had quite a bit of lack of oral stimulation, like when they've been placed on an NPO status. So children who have not experienced normal oral feeding are deprived of that calming sensation with sucking during breastfeeding or bottle feeding. And they also have missed out on a lot of satisfying stimulation, such as putting their hands in their mouths or mouthing toys. And this does not allow for what we are going to call normalization. And we're going to talk more about this coming up in the next slide. All right, let's talk about some of the initial things that we need to be aware of to treat a hyperresponsive gag reflex. We're going to talk about why that treatment is so important. So I've listed some activities below, but we want to talk more specifically about how each one is important in the entire process. When a child comes in and needs oral motor exercises completed because of oral motor deficits related to feeding, we're going to look at that child as having both the oral motor component and oral sensory needs, because we can't just jump in and do exercises if a child has a hyperresponsive gag reflex. We also want to look at improving a child's acceptance of food. So if food alone causes a gag, then oral eating is going to be negatively impacted. And when a child has significant gagging and then could lead to vomiting with feeding, it's going to be a very difficult road to follow to get that child to have a happy experience with food, since that child has had such a negative experience in the past. When we're doing all of these activities, there's many parameters that we need to keep in mind. And the three that I think about most often are speed, pressure, and type of input. And I used a yield sign on this slide because I think it reminds us to slow down no matter what we're doing. Do it slowly. Don't go too quickly, because then we might have to backtrack, and we'll talk about backtracking later. And it really doesn't matter where we are. We could be on the child's body first. We could be at their face, but we still have to keep all of these parameters in mind. So when we talk about speed, obviously we're talking about how fast we go. And it could be how fast our hand is moving. It could be how fast we're progressing from the body up to the face, and how fast we actually move through all of those tools that we talked about on the previous slide. How fast do we introduce them? Most children would not be able to tolerate a hand, a gloved hand, a washcloth, a toy, and a tool all within the same session. We probably have to space it out and have the appropriate speed on when a child is okay with one tool or one type of input and then moving on to the next one. Okay, and then our last case is a 3-year-old girl who has been referred for feeding therapy due to having difficulties with taking solid foods. Her mother has reported that her daughter did not have difficulties with bottle feeding or baby foods. However, when solid foods were introduced, she would attempt to chew them, but then would end up spitting the food out. The girl's mother reported that she tried forcing bites of food into her daughter's mouth to get her to take more solid foods. And despite that, the 3-year-old girl has learned to actually eat some solid foods. However, she has been having gagging on many other foods for quite some time. All right, our 2 questions here for case 3. What could have gone wrong with foods in this scenario? And then what signs of difficulty regarding a hyperresponsive gag reflex do we see? So again, I'll give you a few moments to get your thoughts for these 2 questions, and then we'll talk about it a little bit.